How to treat patients with dementia that have trouble swallowing. Like many neurodegenerative diagnoses, patients with dementia can have difficulty swallowing. In fact, dysphagia is a part of the disease process. The cognitive communication deficits that are a part of dementia can also sometimes make dysphagia evaluation and treatment confusing or difficult. So what's an SLP to do? For SLPs who work in the medical setting, evaluating and treating patients with dementia is a common part of our job. As always, no two patients are alike, and patients with dementia can vary greatly in their clinical presentation. Today we're going to be covering this very important topic. How do we treat patients with both dementia and dysphagia? Let's dive in.
I'm Teresa Richard. I've been a medical speech pathologist for 15 years. I'm a board-certified specialist in swallowing and swallowing disorders. I'm the founder and CEO of the MedSLP Collective and MedSLP Education.
The evaluation. Complete your clinical swallow evaluation, including the cranial nerve exam or oral motor exam. As outlined in a 2009 article published in Clinical Medicine by Smith and colleagues, it's important to dig into the patient's medical chart and interview caregivers and medical staff to understand the following. The patient is in the hospital. Why were they admitted? Is this an acute or chronic problem? What has the person's level of functioning over the past few days, weeks, or months been like? What do caregivers perceive as the problem with eating and drinking? Can the person consent to assessment and intervention? What stage of dementia is this person in? Which food and drink textures did the patient have at home? How does behavior impact the problems or symptoms? Could swallowing difficulty be due to medication effects? Does the patient have advance directives, or does the family know the patient's preferences? Depending on your patient's ability to follow directions, you may need to get a little creative. For example, have the patient imitate you. Write down the instructions. Observe them laughing or smiling, moving their face in other ways in conversation or in other situations if they won't do it on command. Leave the room and come back. Anything to accomplish as many tasks as possible. Part of your assessment can include a skilled observational assessment at mealtime. Now, this isn't just an opportunity to watch someone eat and count how many times they cough. Rather, it's the skilled observation of eating behaviors. There's a free observational checklist you can use called the DMAT, which is the Dementia Mealtime Assessment Tool. You might encounter physicians resisting the idea of completing an instrumental swallow assessment for a patient with dementia. However, we all know that we can't get a complete picture without instrumentation. Unless contraindicated because of goals of care, like not wanting further interventions, or your patient is medically unable to participate, patients with dementia can benefit from video fluoroscopy or FEES. Consider which test may be more comfortable for them. For example, FEES can be completed in a familiar room with their favorite foods and caregivers assisting. For video fluoroscopy, consider whether or not there's a mobile service in your area where caregivers can assist or be present for the study. If not, could a caregiver go with them to the hospital for an outpatient video fluoroscopy to help keep them comfortable and able to participate? For all patients, it's important to consider goals of care. This remains especially important for our patients with dementia. Remember that we don't order tests that don't affect management. If your patient or POA has made it clear that they do not want to participate in further medical interventions, then video fluoroscopy or FEES is likely not indicated. Have a conversation with the physician, patient, and family about how SLP services, a thorough swallowing evaluation, and your recommendations can fit into the patient's life and goals. One member of the MedSLP Collective shared an inspirational story about a patient she was serving who had advanced dementia. This patient had been placed on nectar-thick liquids because he was coughing with thin. The SLP dedicated 2 weeks to explaining FEES, the risks and benefits of it, and even showing video examples of FEES to this patient's power of attorney to discuss potentially completing a FEES exam with the patient. The physician was on board with the study. However, the patient's POA wasn't sure if the patient would tolerate the FEES. The POA eventually agreed to move forward with this instrumental swallow study, and everyone was surprised and excited to see the patient tolerated every second of the procedure. Throughout the 8-minute scoping, and objective swallow testing, the SLP was able to test positioning and different strategies, which led to a final recommendation of thin liquids. This is an excellent example of not allowing a patient's diagnosis of dementia to immediately prevent instrumentation and best practices, which in this case led to the best possible outcomes. I personally have scoped many patients with dementia in the nursing homes, so it drives me nuts when I hear that patients with dementia can't tolerate a swallow study. You just truly never know until you try. Now that we've discussed evaluation for patients with dysphagia, we'll talk about how SLPs may focus on rehabilitative treatment or compensatory strategies for dysphagia management. And later in this video, I'll also cover end-of-life considerations for our patients with dysphagia. Stick around for a 5-part freebie coming at the end of this video. Also, don't forget to check out a few podcast episodes on this topic, which I've linked in the description below. Let's move on to therapy. Can we do rehabilitative dysphagia therapy with patients with dementia? The short answer, yes. The slightly longer answer, it depends. It all depends on the individual patient, what the specific impairment area is, and what the physiological deficits are. It's very possible to see patients who are in memory care, hospice, or palliative units with treatment plans that are exercise-based in conjunction with PT, OT, nursing, and the dietitian to maximize individual outcomes. For some individuals with a diagnosis of dementia, it may mean teaching caregivers strategies for carryover or providing and educating others on visual aids. As one of the mentors in the MedSLP Collective who specializes in dementia care put it, a diagnosis of dementia does not exclude an individual from benefiting from functional and physical-based treatment approaches. The muscles and structures can still be rehabilitated depending on what instrumentation shows as impaired. A dementia diagnosis does not mean that rehab no longer works, only that we, as the therapist, may need to modify our approach to assist in facilitating muscle re-education. Ways to modify your approach might include frequent breaks, redirecting the patient, frequent demonstrations, and biofeedback. Also consider the patient's medications and how their medication might impact their level of alertness and ability to participate in dysphagia exercises. Sometimes you might have to coordinate with the nurse to plan your therapy around the patient's medication schedule. Also, it's important to monitor the patient's mood and let them lead the session. We cannot force therapy in any situation. Ultimately, exercise-based dysphagia therapy shouldn't be automatically ruled out just because a patient has dementia. When you consider the patient's cognitive function, goals, level of alertness, and caregiver support, you should be able to create an exercise plan just as you would with any other patient, while incorporating any necessary modifications. A friend of mine shared a story with me once about a patient with mild to moderate dementia who demonstrated dysphagia on video fluoroscopy. Using biofeedback and one-on-one cueing with the SLP, the patient was able to participate in 3 weeks of dysphagia therapy, targeting laryngeal vestibular closure, laryngeal elevation, and hyoid excursion. The repeat video fluoroscopy revealed major improvements, and the patient was able to return to eating regular textured food and thin liquids. Therapy, compensatory strategies, and end-of-life care. Some patients with dysphagia and significant cognitive communication deficits are unable to participate in rehabilitative therapy. In this case, focusing on compensatory strategies and caregiver training is more appropriate. Choose compensatory strategies based on the patient's deficits. For example, does the patient demonstrate poor attention? Reduced distractions in the environment? Poor initiation? Consider spaced retrieval or visual cues to help the patient remember to pick up a fork and start eating. Visuospatial deficits? Consider bright contrast between plates and food. Make sure the lighting in the area where the patient is eating is bright enough. There are many more examples in the freebie at the end of this video. Other things to consider include hand feeding. Whether it's a caregiver or an aide, some individuals may need to be hand-fed. Food preferences. Make sure to find out from the patient's family members or caregivers which foods the patient typically prefers at home. It's not uncommon to see patients with dementia prefer sweets. Familiar eating and drinking utensils. If family members can bring cups or plates from home, it might improve the patient's oral intake. The more familiar we can make the eating environment, the better. Adaptive drinking and eating equipment. There are cups with slow flow lids or mouthpieces to help control bolus size, as well as slow flow straw devices to assist with bolus control. These are excellent devices to have ready during instrumental swallow studies to see if they can help. Feeding tubes. Research has shown that PEG tubes don't necessarily always prevent aspiration, and long-term alternative means of nutrition could actually cause more harm in patients with dementia, especially end-stage dementia. SLPs hold an important role when discussing the pros and cons of feeding tubes with caregivers and the medical team. So what about end-of-life care? According to ASHA, SLPs contribute to the overall quality of life of patients nearing end of life. The goal of intervention at this point is not rehabilitative, but facilitative. If a person has a swallowing difficulty, for example, the SLP works with the patient and caregivers to develop compensatory strategies that will allow the patient to eat orally for as long as possible. The SLP may also be asked to participate in team decision-making regarding the use of alternative nutrition. SLPs can work alongside the MDs or palliative care team and nurses to determine goals of care as they relate to eating and drinking. Considering a comfort-based approach with acknowledged risk of aspiration may be appropriate. The expected outcome of intervention at this point is not necessarily that the patient's abilities will improve, but that they will be able to use the abilities they still possess to enjoy favorite foods, if that is their wish. The SLP may also be asked to participate in team decision-making regarding the use of alternative nutrition, for example, tube feeding. But remember, feeding tubes are not indicated in advanced dementia. Per the American Geriatric Society, feeding tubes are not recommended for older adults with advanced dementia. Careful hand feeding should be offered because hand feeding has been shown to be as good as tube feeding for the outcomes of death, aspiration pneumonia, functional status, and comfort. Furthermore, tube feeding is associated with agitation, greater use of physical and chemical restraints, healthcare use due to tube-related complications, and development of new pressure ulcers. Efforts to enhance oral feeding by altering the environment and creating patient-centered approaches to feeding should be part of usual care for older adults with advanced dementia. And we'll link that citation in the description below. One SLP shared a story with me about how she provided evidence to the patient, their family, and the physician surrounding that AGS statement I just referenced. The palliative care team and SLP were able to address goals related to feeding together and guide the family towards a more appropriate recommendation of comfort feeding only. The SLP then took it a step further and found a decision guide for patients and caregivers when discussing feeding tubes and dementia. She set up an in-service for the internal medicine team and resident physicians to discuss dementia and PEG tube recommendations and highlighted techniques for them to consider when having this discussion with caregivers, while providing them with a decision-making handout for them to use as a guide. This had an immediate positive impact on patient outcomes as fewer PEG tubes were being inserted, resulting in fewer hospital readmissions related to PEG tube failure and aspiration pneumonia. Want to dive a little deeper on assessing and treating dysphagia with people with dementia? Click the link in the description to access part 1 of our 5-part resource series titled Cognitive Considerations When Assessing and Treating Swallowing with People with Dementia. Or you can go ahead and join the MedSLP Collective membership to dive into all of our webinars, resources, journal club discussions, and online discussions on this very topic. Head on over to www.medslpcollective.com to learn more.